So today I'm going to talk about people living with HIV who are not on medications, which is, I think, a really interesting population. So, I mean, our antiretroviral therapy has been a huge public health success. But we still have a situation where there's people who have a life-threatening condition but are declining life-saving medication, much to the frustration of many of those in their lives. And you can see that the cascade suggests a fair number of people are not taking any retroviral therapy across all racial and ethnic groups. And in New York City, we do a little bit better than the national numbers. About 74% are estimated to be virally suppressed. But we haven't reached our 90-90-90 target in people of color. So you can see among white, 93% of those who are treated are virally suppressed, and 80% overall are suppressed. But if you look at African Americans, 85% who are treated are suppressed, which is still pretty good. So I think our public health system and our clinical systems are working well. And 67% of those who are infected are suppressed. But we still can do better. So our overarching questions in our research, these are like our big questions. I think they're questions that probably everyone in this room is working on. Why do we have these racial and ethnic disparities in HIV incidence? Why do we have these disparities in HIV outcomes? And what can we do to achieve health equity in HIV? So a lot of this talk today is going to be about the why and a little bit on what we can do about it. So I would say it's a little hard to tease out how many people take antiretroviral therapy, how many they don't. I think it's because it's a moving target. But we know that people stop and they start. I just read a transcript of someone yesterday, a guy who started and stopped 14 times over his HIV career. And the NHANES did a sort of snapshot point in time and found that about half of those with HIV were on antiretroviral therapy. So this is an issue that every clinician is going to deal with, stopping and starting antiretroviral therapy. And the people who are most likely to do it have this confluence of sort of risk factors, this intersection of risk factors, low socioeconomic status, mental health concerns, substance use. Women are a little more likely than men, and then African American, Black, and Latina Hispanic populations more likely to be the stoppers and starters. So today we'll talk about why, and we'll talk about some of the issues related to structural racism, and then I'll walk you through an intervention study that we recently completed to address this problem and what we think worked and didn't work in the intervention. I'm going to present qualitative data. I'm going to probably just hit some highlights, but you can have copies of our slides, and most of the work that I'll talk about today is published, so you can have access to the papers too, but I won't have time to go into too much detail. So I really like this quote: every system is perfectly designed to get the result it gets, and I sort of keep that in mind as we talk about racial and ethnic disparities. It's sort of not shocking if you think about some of the structural causes that people of color and low SES populations are more likely to not want to take medications. And in keeping with that quote, we're interested in structural racism, and that's the macro level systems that reinforce inequalities among racial and ethnic groups. And it's a little bit invisible in some ways, but very influential. It can be things like even infrastructure, not running subways in certain neighborhoods, unequal resources, disproportionate criminal justice involvement. And out of structural racism comes critical race theory, which is a nice model to try to understand how structural factors may influence individual health behavior. And so there's a nice little book on critical race theory you can read in a few hours that will do a better job than I will in describing it. But one aspect of critical race theory that we're guided by is centering the margins, really getting into the perspective of the population and having them explain to us why we have these problems. Can they do that? So we asked this research question: what are African American, Black, and Hispanic persons living with HIV/AIDS, that's the acronym, perspectives on how living in a structurally racist society affects individual health decisions and behaviors? Actually, I'm going to give credit to our qualitative data analysts for coming up with this question. I would have never asked this question because I would have thought it would be impossible to answer. but he asked it of our data set and participants answered. So just very quickly summarizing some qualitative findings. They said 4 main things in response to this question. The first thing they said was that the fact that HIV care settings feel institutionalized to them is a barrier to being on antiretroviral therapy. It reminds them of other institutionalized settings, whether it's sort of welfare or criminal justice. They don't experience discrimination from providers for the most part, but they feel dehumanized. They feel stereotyped. Here's a quote: "Something invisible was speaking to me when they walked into a setting." So that's one type of barrier. Medical distress, this is one you're all very familiar with, and I think is still a very important one. There are very deep and lively counter-narratives about the origins, treatment, and the cure for HIV. So counter-narrative or counter-storytelling is the term used in critical race theory for what other people call conspiracy theories. Conspiracy theories suggest that they're not true. A lot of the counter-narratives are true or have basis in truth and maybe have evolved over the years and sometimes be worse than what actually happened. But in keeping with critical race theory, we accept the counter-narratives at face value. We don't necessarily agree with them, but we accept them as truth to be respected. In the context of medical distress, side effects are huge. So say if I was living with HIV and I took antiretroviral therapy and I had a side effect, I would think, well, it shows me the medication's working. I'll call a dog walker, you know, it won't be a big deal and I'll be fine in 6 weeks. But for many people, side effects trigger the counter-narrative. They trigger the feeling that there's a cure for this disease that they're withholding from us. The treatment is designed to kill us. The treatment in the past did kill us, referring to early AZT treatment. So the side effects are a really big deal. So what you'll see a lot is people will take antiretroviral therapy, and the side effects aren't even that bad at this point, have side effects and stop the next day because the emotional aspects of the side effects are so huge. The third theme that came up in light of this research question was feeling a lack of autonomy in medical decision making. And I actually have been surprised at how much this comes out as a theme in all of our studies, actually. People will say they want to initiate antiretroviral therapy when it's right for them, but they feel pressure from providers to initiate. They feel judgment if they're not on antiretroviral therapy. I am completely sympathetic to providers. Providers are trying to offer people access to a fabulous, life-saving, tolerable medication regimen. They're doing their job, and they're under pressure, too, to get their patients on medication. So there's an unfortunate interaction of effects here. And just generally feeling they're excluded from the decision-making process. And as one participant said, I don't have a voice because I'm Black. And one thing I love about qualitative research is we bring their voices out where all can hear them, and it's such a privilege to be able to do that. Then the last thing they said, and you can see the themes are all related, is they don't feel they're treated as a whole person. You're focusing on one thing. I'm bigger than the pill. So I'd also like to add that substance use is a really big issue. People fear if they're using, even casually or occasionally, that there are antiretroviral and street drug interactions. They can't really talk to providers about that. And then they also fear committing to antiretroviral therapy because of their substance use. And there's really no place to work it out. And then at the bottom is the diversion to pharmacies. People probably for about 15 years or 20 years have been selling their medications to corrupt pharmacies. These pharmacies open and close. There have been prosecutions. The price goes up, the price goes down, but it's really tempting for someone if they go to fill a prescription and someone offers them $100 or $150 for their medication. So this is a big issue for everyone, but for substance users in particular. And then there's so many other barriers to antiretroviral therapy for this population. It starts to get a little overwhelming at this point, wouldn't you say? Poverty, social norms. Some of the social norms are positive. Some interfere with medication, as I said, stigma, trauma, depression, lack of social support. So we have a serious situation. I'd just like to say, this analysis of structural racism is guiding our work. I think it's useful to know that the population is acutely aware of the societal level inequalities, and that antiretroviral therapy and HIV care, in essence, are experienced through a social, historical, and cultural lens. You know, I was mentioning about the side effects trigger the counter-narrative. You know, all the counter-narratives are sort of indications of the lens that they experience. So someone's view on antiretroviral therapy can be very different depending on their position in society. They also, of course, have motivation for good health and well-being. I mean, who doesn't? And so sometimes the fear, because this is all very emotional, and the desire for good health can kind of paralyze them, and we're trying to break that log jam in our research. So here's a very, very simplified model of what seems to be going on. So we have structural racism. It manifests in this institutional stress, the counter-narrative, autonomy, and then it comes down basically to emotional barriers, fear. So when you fear something, you avoid it, of course. And when you feel pressure and you have fear, you avoid it even more. And all of this undermines motivation and readiness, and then what you get is people declining antiretroviral therapy. But of course, it makes sense if you talk to them why they might want to do that. If you ever look at a map, you can see how structural HIV is, and Bob and I were talking about this. All the bad stuff happens in the same place. The poverty, there's the Bronx, where Bob's from, Central Brooklyn. It's not your fault, right? And then HIV diagnosis rates map onto poverty, prevalence maps onto the poverty, and then death maps onto the poverty. These are manifestations of the structures of our city. So we know all this, and then we want to develop behavioral interventions for people of color. I'm a clinical psychologist. I really enjoy working with individuals, families, and social networks. You could say we should do structural interventions. I completely agree. Interventions with providers, yes, please do. Interventions with organizations, yes. This is what I love to do, is work with individuals. And at the end of the day, someone needs to take a medication, so I do think there's very good value in that. So I'm not going to go through all these, but these are the kinds of things we're thinking about as we develop intervention. Emotions, the fact that we need durable intrinsic motivation for health behavior. I mean, one problem with adherence interventions is they don't last very long, and that's what we're really trying to tackle in a lot of our work. Looking at people's strengths and natural forces of health and behavior change, thinking about cognitive biases, which I'm not talking about today, but you could not find a more complicated thing than a human being. Just the crazy things we do, and the way we're so focused on the short term and we don't look at the long term, and it's just the way our minds work don't lend themselves naturally to things that have like a long time horizon or even prevention. And then taking into account individual differences within the context of culturally based interventions. So what do we mean by culturally based interventions? I've been thinking a lot about this, and I've been looking at a lot of intervention manuals. Everyone knows that populations of color are going to be overrepresented in the groups that we're working with, but I think a lot of our interventions have been colorblind, and I would say that that's true of mine and ours as well. But so what we're doing now is making them not colorblind. Where race, structural racism, and discrimination are acknowledged in the intervention as reasons for the problem. One way we do that is we have video narratives where we put all the issues on the table, facilitated discussions, use of peers, and as I mentioned before, the understandings, that's the word of critical race theory, or the counter-narratives are accepted at face value. It doesn't mean you agree with them, but it also means you don't immediately dismiss it. I actually was looking at a transcript yesterday of someone who has a lot of counter-narrative beliefs that there's a cure that's being withheld, the medications are toxic. He is taking antiretroviral therapy. But what I sensed in his transcript was the incredible frustration to have his counter-narratives dismissed out of hand. And I don't blame healthcare providers because there really is not time to unpack that in a 7-minute clinical encounter. You have a lot of other stuff you need to do. But I do think as a field we could probably do better at listening and understanding and respecting these counter-narratives, because if a whole population is saying something, they're trying to tell, the group is trying to tell us something, and I think we could do better at listening to it. So this can be a little tricky because I do not believe HIV was created by the government to kill populations of color. I do not believe that a cure is being withheld. And I do not believe that antiretroviral therapy is designed to kill people. Quite the opposite. So we have to balance our stance and respecting counter-narratives. And then we try to just, of course, address barriers people of color face to health equity. And then there's a whole intervention that I really love on culturally based interventions. The messaging, Resnick's a leader in that field. And they talk about combining history, culture, and core values as a medium to motivate behavior change. Without motivation, you don't have a lot. And I think it's worth looking at that literature. So when someone is going to go on antiretroviral therapy, this is what it seems happens for most people. We start thinking about this. We're going to identify barriers to adherence. We're going to identify solutions and supports and resources, pillboxes and reminders, and then help people build adherence skills, and then they sustain antiretroviral therapy with good adherence. And all this stuff that I'm talking about, negative attitudes, distrust, fear of stigma, social norms, substance use, it's sort of putting pressure on this, and it's dealt with a little bit here, but it's not really directly unpacked and directly addressed. But for a lot of people, that works fine, and you don't really need to do too much on this. There's enough impetus that this works. But for the populations we're working with, we are sort of backing up and thinking of unpacking the cascade a little bit and thinking about all these steps that go in before you decide to initiate antiretroviral therapy. So you're offered it. First you consider it, you prepare for it, and then we put a lot of emphasis on this, the decision to initiate. And all of these things go into this. The fear, you might need to shed a tear, distrust, stigma. I mean, one thing our participants have really taught us is that stigma operates so differently if you're poor. So if I had HIV and I experienced stigma, that would hurt me deeply, no question. And I would be very upset about that. But what our participants are saying are, I'm living on a razor's edge. If I experience stigma and I lose like a key relationship, like say my grandmother, that could be life or death for me. I could get thrown out of my house. I could lose everything. I don't have it to give. I can't take this risk. So stigma is a very, very big deal if you're poor. So this is sort of our focus now, which is building social and emotional readiness to initiate antiretroviral therapy, and also at the same time motivation to do it. You want to do it. I think a lot of times we skip over that step, and for some people that winds up being problematic, and then they're not ready, and they don't have the motivation, and they stop. So we have an integrated theoretical model, critical race theory, as I mentioned. Self-determination theory it's an accepted basis of motivational interviewing, which I assume you're all familiar with. Are you? Yeah. Okay. Too familiar, sick of it? I still love it so much. It's so simple yet so complex. And that's the core tenets of self-determination theory are autonomy, relatedness, and competencies. So autonomy is all the things that came out in our qualitative analysis, people just really feeling like that was so important to them. And I'm going to say that that is, to me, a true discovery from our research. I would not have, I mean, I would think autonomy is important to everyone, but I wouldn't have necessarily predicted that autonomy would come out so strongly as so important to people in this context, but it has come out in our research. And then social cognitive theory, our little workhorse theory, is integrated with that. And so this is what the model looks like. These are the things we try to target in our intervention: attitudes, emotions, health beliefs. These are like sort of positioned as mediators, but I'm going to say in our past research, we don't really see changes in distrust and fear. We address it in the intervention, but we don't see a change. Health beliefs, we don't really see changes in any of these things, but they're still positioned as mediators. Social norms, and then just some structural influences. We try to complement the healthcare encounter in our interventions. There's a short appointment time, and we talked about some of the issues with the providers. So we did just a small randomized controlled trial. It was an R34, and we had 95 people enrolled, randomly assigned to arms. They got an interview right after the intervention, and then a follow-up interview about 8 months later, and then we did a qualitative interview. And at the time they got their follow-up interview, we took a hair sample to test for antiretroviral therapy, and I know a lot of you here are doing that. Monica Gandhi's lab does the analysis, and we got medical reports, CD4 and viral load from their healthcare providers if they had them. So here's what our intervention looked like. It had several components. We did intervention sessions, motivational interviewing intervention sessions with participants. We had videos to get all the issues on the table. We had a support partner join one of the intervention sessions to support long-term adherence. And we had support group meetings led by a successful peer who was on antiretroviral therapy and was engaged in care and interventionist. And then patient navigation from 12 to 24 weeks to help to resolve any other barriers that they might have to initiation if they wanted to, like substance use treatment, mental health counseling. These actually are hard barriers to overcome for a lot of reasons, but the need is great. Refer to adherence counseling. We didn't think of this as an adherence intervention, and we weren't there to reinvent the wheel. We did a few things in navigation to prepare the adherence environment and support adherence. We could connect to providers if they didn't have one, that kind of thing. And our endpoints were ultimately viral suppression. We also looked at some other, adherence and engagement in HIV care. So Heart to Heart is the name of the intervention. It has a relationship to adherence interventions, and it's not an adherence intervention. It's sort of like a pre-adherence intervention, and it is intended to complement adherence intervention. So if you're not ready to take any antiretroviral therapy, adherence interventions really aren't appropriate for you. And we did refer people to adherence programs in clinics, if they wanted to do that. The main eligibility criteria, 18 or older. This was done before the guidelines changed to CD4 less than 500, African American or Latino, HIV infected for 6 months and not taking any antiretroviral therapy for the past 6 months. That was actually so hard to assess because people stop and start. And also, it's one of these things that's really affected by, one, social desirability bias, but also people's desire to get into a research study. So this one, there's always lessons learned in research. This one was a hard one, actually. And we're trying to do it better in our future studies and by self-report. This is our CONSORT. The main thing I wanted to tell you is that we screened a lot of people to get our 95. We didn't screen them in person, but we started to recruit from clinics. Our plan was to do this at 2 HIV clinics, but they are not there. That was another lesson learned. They do not go to HIV care. If you're not on antiretroviral therapy, you don't go to HIV care. So that was a bust. The R34 is so brilliant, because you can adapt. So when I saw that this was going nowhere fast, we added a community recruitment component. And we had peer referral, and we did some some outreach, and we managed to get her sample, which was fine. And we had good retention to intervention, and we had good follow-up. And I'd say one thing about the intervention is even people who had no intention of ever going on antiretroviral therapy could engage in our program. We had activities for them if they didn't want to talk about it. So here's one of the lessons learned that I was hinting at. Right. So if you in HIV care, obviously you have no access to antiretroviral therapy, but what we found is people who are avoiding antiretroviral therapy avoid HIV care. So you're not going to find them in clinics. Just briefly, our demographics, they're on the older side, mostly African American, substantial proportion of sexual minorities. Substance use was pretty high. The clinic, higher in the clinic than the community, and depression was substantial. They lived with HIV for quite a long time, 16 years on average for the community. That's a long time. Selling medication or diverting medication was fairly common in the community cohort. And everyone in the clinic sample obviously had been in care, and that was very low in the community cohort. All right, so here, I don't have it here, but they had stopped and started antiretroviral therapy many times. There were very few who were treatment naive. All right, so let's look quickly at some of our efficacy. This slide has, these are our non-significant findings. So the intervention didn't influence HIV appointment attendance. About half went to care in the 6 months prior to the follow-up interview. All the providers pretty much recommended antiretroviral therapy. Most of them wrote a prescription. And we found about 60% initiated antiretroviral therapy in the period, no difference between arms. So most 60% went on, and they all pretty much continued. But we did find some differences between groups in adherence. So here's some evidence of efficacy just on adherence. So I mentioned that most initiated antiretroviral therapy, and among those who did, those in the intervention arm had better adherence measured through these hair samples than those in the control arm. So what it turns out to be is 60% had 7-day-a-week adherence compared to 27% in control. So this test says that it's not a significant level, however. So this says to us that participants tended to initiate antiretroviral therapy in both arms, and those in the intervention arm tended to be more likely to take it, every day, every dose every day, which is the goal of adherence. We did find significant differences in viral load. Those in the intervention arm, you can see if they didn't initiate antiretroviral therapy, that's 40% no difference. But if they did, those in the intervention arm had significantly lower viral load than those in the control arm. And 74% in the intervention arm reached undetectable levels, not at a significant level compared to 48%. So this, to us, is a big effect, a large effect size, and you can see the difference in viral load from the intervention. So we were pleased with this effect and felt that it was promising. So then we wanted to understand what participants had to say about the intervention. You know how you're supposed to have equipoise when you do interventions? Okay, so of course you never do. But I really did have equipoise with this intervention, because I really didn't know if you could grab someone off the street and say, let's look at this decision together, and that people would do it. I mean, our first participant came in, and her name was Claire, and she burst into tears, and she said, I know I need to do this, and maybe this will be the push that I need. She went on antiretroviral therapy, and she was undetectable in 3 months. So that was good. Our second participant said that we were telling him the same lies and misinformation as everyone else. HIV doesn't cause AIDS, and it was a horror what we were doing. So, of course, he would never go on antiretroviral therapy. But I'm going to tell you, he stayed in the study and did his follow-ups and did a qualitative interview with us. So I give credit to the motivational interviewing approach for rolling with resistance because, you know, that's a tough one. I'm not going to argue with him, but he was very angry and unhappy about what our intervention was about. But he did stay with us. It was his choice. So we did this qualitative study just to understand what they took from it, but also, is it useful to talk to people about race, ethnicity, and class? You know, we have a multicultural staff, but you have white people as facilitators. What's it like to engage in that? Is that useful? So we did a qualitative study, you know, embedded in the quantitative study, and we've used propulsive sampling for maximum variation. So this is what the sample looks like. Pretty similar, actually, to the larger cohort. There wasn't tons of variability. So here are the results. I'm going to walk through very briefly again, just because we don't have time. This is what they said was the most useful. I'm going to tell you a little bit about each one of these levels. So motivational interviewing, time, and whatnot. So let's go through these one by one very quickly. So participants said that the absence of pressure or judgment was a core aspect of the intervention that fostered trust and honesty. We would explicitly tell them, no judgment, no pressure, sort of our tagline, heart to heart, no pressure, no judgment, no pressure, no judgment. Your choice, your choice. And that, they heard that, and that was a really, really big deal. And also they said, I never have a chance to talk about why I'm not on antiretroviral therapy. So that was very unique. And it did seem to help a process of personal decision making, which I think is really appropriate for antiretroviral therapy. Maybe if you're not on every year or every 6 months, you should just take a step back and think about if this is what you want to do. So we have some quotes, but they are basically about the autonomy. I didn't feel judged. I didn't have to do anything I didn't want to do. That's a big plus. And you know, they do feel judged. They feel judged by other people living with HIV. They feel judged by their families, by providers. They know that they, quote unquote, should be on medication. So like this person said, you just look stupid. You don't take your medication. You know you could die. Right, so that was one finding. Similarly, support for their choices. It's a little paradoxical, but validation of the option not to initiate antiretroviral therapy seems to free up participants to think about doing it. You know, we say people often don't take antiretroviral therapy. There are reasons for that. We can talk about that. It's sort of similar to the other one, but they help me feel like this is your decision. It's still my decision. And this came out very strongly in our transcripts. I think overall, the culturally based intervention components were helpful for most people. The way we set things up is people have choices, and if they don't want to watch videos or they don't want to talk about something, they don't have to. For some people, it's not relevant. For some people, it's painful. So the choices are helpful. You know, this is a very emotional decision. Some people want to tackle those emotions. Some people don't. But overall, I would say putting this on the table, mentioning the history of experimentation, using the term guinea pig, which is very resonant for people of color who have been used as guinea pigs without their consent in medical research, allowed people who wanted to talk about that to talk about it. I mentioned before that we had video components, so in this one quote, the videos made me feel like that's me. So to me, that's a tremendous success. That was the point. The videos actually had dyads, one where the person was not on antiretroviral therapy interacting with his family member, and one where the woman was on antiretroviral therapy interacting with her family member, and then they interacted. And I was just trying to get all the issues out on the table about what people typically say about this and give people permission to talk about them. This one said they had a lot of videos where people were asking similar questions to what I might have had in my mind, but never really asked, didn't know who to ask. And then this one, it's not what you learned about it, but how you feel about it. I think this is really important. I think our interventions, my interventions, have been probably overly cognitive, thinking about skill building. Even social cognitive theory is very cognitive, obviously, and social. But I think a lot of the action for this is emotional, but it's actually it's complicated for us as interventionists to get at this, I would say, and it's complicated for us to assess it. And part of that is my latest hypothesis, which I don't know if I can test, but I haven't looked to see if I can. So you know this book by Kahneman, Thinking Fast and Slow, and they talk about the two systems. So system one is this very quick, intuitive thing. Like if I said, do you want to go to Croatia? You're not going to think. You just tell me, yeah, yes or no. If that's your thing, you say yes. If it's not your thing, you're going to say no. Versus system two, which is like thinking, your pros and cons, your reasoning through something. I think we're trying to talk to system one, and I think that's where the action is, system one. So someone comes in, I have an aversion to antiretroviral therapy. Sort of reasoning through it, for some might help, but I don't know if that's really where you're going to get the most action. But sort of feeling your way through your decision, I think, is where you get a lot of the action. But that's why I think we don't show any change in our scales of distrust or fear or anything, because I think we're talking to system one, and it's sort of not in this conscious level.
I just wanted to follow up on that. I think that's a great theory, and I often think about those systems. As a clinical psychologist doing psychotherapy with people, I think often you're working with system one, but you're tricking system one to actually be system two. By exploring all the feelings, spending a lot of time on all the feeling stuff, you're actually engaging system one and system two work. So that's how I think about it.
And have that work out for you.
Yeah, I mean, I want to think about what you're saying, but it makes a lot of sense. And I just started reading Thinking Fast and Slow, where they talk to, I mean, they're not completely separate, but they don't typically talk to each other, but they can talk to each other. Well, I'm glad that you think that this makes sense. I'm going to keep thinking about what you said. Can we trick system one? Well, can we engage system one? Another finding from the intervention. So, healthcare encounters are short. We have a lot of time with people, and I really do think interventions like Heart to Heart can complement the healthcare encounter, because it does take time to elicit and process decisions, emotions, and individual concerns. We also have to build relationships with people. They didn't know us, so we're asking them to do something hard. And if someone grabs you off the street, sat you in a chair, and asked you to look at like your eating, or your exercise patterns, you can just immediately launch into telling your deepest, darkest secrets. You need to get to know someone and build trust, and they have to be good. They have to be skilled to make someone want to do it. This is not something you would have like a person who's not clinically trained do, because you have to be worth their time, and I really do believe that. So this person said the facilitator matters. Someone you can talk to, can walk you through the process. I hadn't talked about antiretroviral therapy in years and years and years. I don't have the platform in which to talk about this stuff. People don't really care or interested in the whole story. And something they took their time with. It wasn't forced on me. And then peers we found were a very powerful influence. I remember one guy said, no offense, but we don't want to talk about it with you. Old lady who doesn't live with HIV, who's white. But I want to talk to someone who's been there, who's walked down this road. And then also, there's so much shame about not being on medication. So this idea, I'm not the only one feeling the same way, hearing other people's reasons. So again, it's paradoxical. We put a lot of people not on medication in a room together, talk about not being on medication, to foster people's decisions, ideally, to go on medication. So it's paradoxical. But for whatever mysterious reasons, it really seems to help people free up a little bit and consider both sides. So I wasn't feeling like I was going crazy. Other people were saying the same thing. if you can talk to someone that's been through it or testimony, that's better than reading it. And then they show you a little roadmap. And people with HIV tend to be very isolated, so this was an important part of the study. One thing that came out in our study that I thought was very interesting is that once they decided to do it, adherence wasn't described as a really big challenge. And so we have all these fabulous things we can do to help people adhere, and I'm a big fan of reminders and social network influences and rewards and pillboxes and everything, and I absolutely think they're vital. But for our people, once they decided to do it, they did it. And we saw that in the quantitative findings. And the goal of motivational interviewing is to develop what they call high-quality, durable motivation for behavior change. I wonder if that's what we did. Maybe they developed high-quality, durable motivation for behavior change. One thing I'll say about our quantitative findings, they were assessed, months and months after the intervention ended. And one of the biggest problems we face in adherence interventions is that the effects wear off. So it seems our data suggests that the effects of this intervention were sustained. And if that's true, I think that probably the number one reason for that would be the high quality, durable, intrinsic motivation for behavior change.
How many months out?
It was 8 months out, about 6 months after the intervention ended. 4 to 6, 7 months after the intervention ended. All right, so conclusions we took from the small randomized controlled trial. Well, I would say if you take the qualitative findings and the quantitative findings together, the approach is promising. It's a small randomized controlled trial and was compared against treatment as usual, so those are limitations, obviously. But the effect was large. We didn't power it for efficacy. So having a large effect size on endpoints was impressive to us, and we felt that it was clinically meaningful. So people in the intervention arm actually had about a log less viral load than those in the control arm. All right, so I want to just tell you a few implications we think for clinical settings, and I'm going to tell you what we're doing with it now. Let me check my time.
Okay. 15 minutes if you want.
Okay. I won't take 15, but thank you. So we've talked a lot about this. I don't want to repeat, but I think we as interventionists really have a role to play in complementing clinical care. We can take some time with people that regular healthcare providers are not going to be able to do. And so I would love to see this intervention implemented in clinical settings. I also think that past research has shown that motivational interviewing is a very good fit for populations of color. And I think our research sort of highlights why this might be, and the themes of autonomy in particular, which is so integral to motivational interviewing, are a big part of that. And this analysis really encouraged me to keep going with understanding how to create culturally based components. I don't think we should be colorblind in our interventions, although I think it's hard to address race and class and other disadvantaged categories, but I think it's really useful. And probably one of the main things I've learned from our participants in this analysis is just how powerful the counter narratives are, how important it is to elicit them and help people sort of work with them. I also want to say with counter narratives, I think the counter narratives just coexist with the non-counter narrative. So people can believe at the same time that antiretroviral therapy is toxic and that antiretroviral therapy is their best chance for a long and healthy life. So I don't think the counter narrative is necessarily a problem, but somehow someone has to manage it. But I think I'm feeling a new level of sympathy for what it must be like to struggle with that on a daily basis. If you have negative feelings every time you take a pill, that's really tough, you know, for you every day. So I guess I'm just coming at this from a place of compassion for people who have to struggle with the fears every day. So as we were talking about, and our clinical psychology colleague agreed, you know, the system one seems to be where a lot of the action is. So we're trying to talk to system one. I think clinical settings could probably do a better job anticipating and normalizing stopping antiretroviral therapy or delaying and reduce pressure, because that seems to be where a lot of problems occur in the clinical setting. People are embarrassed to tell their providers they've stopped. They don't. Sometimes they say they're taking it, but the provider obviously knows they're not. That can go on for years. You have a lot of pissed off providers. You have a lot of embarrassed patients. There's just a lot of frustration all along. And people are most likely to stop antiretroviral therapy when they have a disruption in housing or there's some kind of serious life change. Just very cyclical. Substance use can flare up. You can lose a key relationship. You can lose your housing. You stop taking medications. You can just expect that that's going to happen. But you want people to get back on the horse as quickly as they can. There's also sort of really interesting work. Have you heard of this idea of structural competency? So these authors, Metzl and Hansen, are trying to extend the idea of cultural competency in medical settings to the idea of structural competency in clinical settings. I think it's a really interesting idea. They have this paper that I would encourage everyone to read, and I think could, you know, I can't show you a direct line about how it could apply to clinical settings, but I think it's some very intriguing ideas. So they recommend, I think they don't have such a good view of cultural competency. I don't think they feel cultural competency really is telling you anything at all. But structural competency might tell you a lot about someone and why they're doing what they're doing. So these are the 5 elements of structural competency: recognizing structures that shape clinical interactions, developing an extraclinical language of structure. That one means that so the structures are outside of the clinic that are shaping the clinic environment. You know, the things like the structural racism we're talking about. Rearticulating cultural formations in structural terms, imagining structural interventions, and developing an awareness of the limitations of our own structural competency. So I just read this paper in advance of coming here, and I'm going to continue to read it because I think there's some really interesting ideas for us as interventionists here. Okay, so next steps. So we have good news and bad news in our world. Good news is heart-to-heart is promising. It seems certainly worthwhile pursuing the next step in this program of research. But the bad news is we have a lot of components, a lot. We have sessions, we have patient navigation, we have support groups, we have the peer, we have the support partner, which actually I didn't mention, that did not work. People did not have someone they wanted to bring into intervention. We have all the referrals. So this is a typical situation that we face as interventionists. We have interventions that have a lot of excellent components, but we don't know which ones made a difference in producing our results. So here's sort of what it looks like in another viewpoint. So they call it the treatment package approach, the classical approach, where we prepare an intervention, we identify promising components, we put them in a package, and then we evaluate it in a randomized control trial. And that's what we've been doing, and I've been doing for a long time. But there's actually another way to handle things, and it's called the Multiphase Optimization Strategy, or MOST. Have you heard about MOST? Okay. So MOST is an engineering-inspired framework that wants to break interventions apart and evaluate intervention components separately. So in most, you prepare, which is what we did, this heart-to-heart with preparation. But then there's a different step, and the extra step, which is optimization. So you use their framework, the MOST framework, in a factorial design or fractional factorial design to assess the efficacy of individual components. And then you can engineer an intervention with any number of criteria. So we're actually using, as I'm going to show you in a second, to engineer the most cost-effective intervention, but you could engineer the intervention that takes the least amount of time. The best intervention you can do in 5 hours, the best intervention you can do for $1,000, or the best intervention you can do that has no inactive ingredients. And then you can evaluate the intervention in a randomized controlled trial. I don't think you have to, but you can do that. So this is what our intervention looks like in a MOST framework, and we are funded by NIDA to do this, and we just started recruiting this week. Ferreting out our participants are very hard to find. So we broke our intervention into 5 components. So the sessions, and each component is linked to a theoretical mediator. So in a way, you're sort of cutting the pie in the way that makes the most sense to you. When I first heard about MOST, which was over 10 years ago, I thought it was ridiculous because as an interventionist, everything interacts with everything else, and you can't separate out a component. It made no sense to me, and I'm telling you, it truly made no sense to me. But now I see that it's how you slice your pie, and you create components that can stand alone and that can be delivered without other components. And so our components are sessions that are intended to change health beliefs and emotions. We have a pre-adherence skill building module that addresses behavioral skills. I like this one actually. I think this is really cool. This is sort of drawn on what's known about how to help people adhere, preparing the environment, but also very heavily drawing on the habit literature. How do you develop habits? So actually go to the house, get very concrete where you're going to keep it, pillboxes, reminders, rewards, and all that stuff. Put that in place if they want to start. Peer mentorship. So we took the peer piece out of the group, and peer mentorship is its own component. And that's intended to change peer models and norms primarily. The focused support group, you know how we get them all in the room just talking about why they're not on medication, to address social support and stigma, and then patient navigation to address structural barriers to health. And then the end goal is they'll be motivated, and they'll engage in care and initiate art with good viral load suppression. And then along the way, we're going to look at the cost effectiveness of each of the 5 components. And then we can put together whichever 1, 2, or 3 are the most cost-effective combination. So the intervention will not have all 5 likely. It'll probably maybe have 2 or 3. And we can put that forward then as something with no dead wood, absolute best set of components for this problem. And it can be disseminated that way or tested in a randomized controlled trial. We'll decide later whether we want to do it. I'm not telling you too much about the design, but we're actually testing it in a fractional factorial design. We have 16 different conditions actually that we're assigning people to. So this is new for us, and I have to say really, really fun and really exciting. And Linda Collins at Penn State is the one who invented this method, and if you're interested in it, you could go to the Penn State website. They have webinars and other stuff for it, or maybe she's even come and spoken here. So that's it. That's our thinking about this problem. Here's our research team at NYU, and we have our partners at what's now Mount Sinai, and funded by NIMH. Right, today. Yeah, it wasn't at the time, but it is now. And thank you for your time.